Hi, everyone. My name is Michelle Shuffett, and I'm here today on behalf of Columbia Care to talk with you a little bit about medical cannabis and opioids. And before I get started, I actually wanted to just share a few stories with you. I was talking with a really good friend of mine earlier this week, my business coach and good friend, Karen Eldad, and we were talking about this topic, and I said to her, first of all, I might be a wee bit nervous because it's the first time I've been in front of people in 2 years. So it's kind of exciting. I don't know if you guys are excited about it, but I'm nervous and excited, so bear with me. And secondly, I asked her, do you still think the opioid epidemic is actually a hot topic? And some chuckles, right? And she laughed as well, and she's like, of course it's a hot topic. She's like, you see it in the news every single day, whether it's political banter, updates on lawsuits, and overdoses. And as a matter of fact, when I woke up this morning and turned on the TV in the hotel room, the very first news story I saw was about 3 people overdosing in a hotel in downtown LA last night. And it hasn't changed. It's still a problem. We went on to have a more amusing conversation, and I won't torture you with all of it, but we also talked about TV shows, things like Breaking Bad. Probably wouldn't have been quite as interesting without the opioid epidemic fueling it. And more recently, I think Dopesick is actually a great example. I don't know how many of you have seen Dopesick? Beautiful show, beautiful show. And I think what Dopesick did is it humanized the opioid epidemic in such a beautiful way from so many different perspectives, whether it was the physician who ultimately became the patient or the people in the rural communities. And, for me personally, the opioid epidemic was humanized by my father. So I grew up in a very small town in Kentucky, and my father was the local country doc, the family practitioner, if you will. And as he started to see what these drugs were doing to the rural communities around us, he got really interested in trying to help. And he'd always had an interest in addiction medicine and that sort of thing anyway. So he went through additional certifications, he got some other training, and he ultimately opened one of the first Suboxone clinics in the area and really helped a lot of folks with this problem. And he made a difference, and I know he made a difference because at his funeral in 2011, there were several of those recovered addicts that came, and they came to pay their respects. They came to say thank you one last time. And I don't share that story because it's a sad story. I share that story because I think it's very inspiring. We can make a difference, and that's the reason we're all willing to take time out of our busy lives and come to meetings like this, is because we truly want to change things and elevate the industry and try to help with this particular problem. So with that, we will jump right in to the lovely hot topic, the opioid epidemic. And these numbers are from 2020 publications, and I think it hasn't really changed since the last time I talked about this on stage in probably 2018. We had almost 2 million folks misusing prescription products for the first time, and over 10 million misusing them on a regular basis. And the death rate has only gotten higher. Over 70,000 people died from a drug overdose in 2019, according to this data set. And when you look at the breakdown, it's not heroin. It's not the street drugs that folks used to die from. It's the synthetic opioids. It's the things that are being prescribed to these patients. And quite frankly, it's very expensive. This call out is from the CDC, and they talk a lot about the economic burden. It's almost $80 billion, billion with a B. And that's total healthcare costs, so that's loss of productivity, that's also direct healthcare needs and things of that nature. So when you think about all these things and you think about everything we've learned over the years, what else can we do to make an impact? What other things can come into play here? And I think we really need to start thinking about the problem in a very different way. And I happen to be a fan of Adam Grant, so I'm going to use his favorite phrase. We need to think again about this and really be open to different solutions and strategies. And I think cannabis gives us a great opportunity to think again. And one of the first folks that opened the door to these possibilities was Bachhuber. And he was an associate professor at Montefiore, and he and his colleagues were hearing, anecdotally speaking, that a lot of the patients were substituting their opioid prescriptions with cannabis when they were able to get it. So they put together a research project, and they started to look at that. And what they found is a really interesting trend. They found that between 1999 and 2010, in states that had medical cannabis laws, the overdose mortality rate from opioids was about 25% lower. And he even went on to predict that medical cannabis would ultimately fall into the category of alternatives for treating chronic pain, so that folks can either lower their dose or they can have a different option besides opioids. And this paper was published in JAMA in 2014. If we move on, NAESM provided even more evidence, the National Academies of Sciences, Engineering, and Medicine, and their report on the health effects of cannabis and cannabinoids came out in January of 2017. And I haven't looked recently. I don't think it's been updated, but if anyone knows, shout out. But it's a beautiful collection, and they determined that there are 3 areas where there's conclusive or substantial evidence that cannabis and cannabinoids are effective. And chronic pain in adults was one of those. So they based this on about 30 randomized controlled trials, about 2,500 patients, and these were all very small trials, small studies. But in totality, they decided that it was a conclusive effect. And I've seen a lot of people talk about this set of 3 as it should be changed to 3+1 now, because we have Epidiolex, which several folks have talked about over the past few days. But ultimately, in a good way, Bachhuber's prediction actually came true. And in the New England Journal of Medicine in 2017, Volko and Collins added cannabinoids to the treatment of chronic pain as a short-term strategy and also as an intermediate strategy. And since that time, and before that time, there's been more and more and more studies. I can't begin to highlight all of them. I just wanted to share a few of the key ones to set up the story, because what we're going to talk about today is real-world evidence. And that real-world evidence comes from the Columbia Care IMPACT database. And IMPACT stands for Integrating Marijuana Program Analytics and Current Treatment. And this database came about because of New York state laws. And many states have these same laws, but seed to sale, you have to track where the product is going from the moment that it comes into existence. And you also had the advantage of having a lot of information from the patient registration process. So you had to, in New York, for example, have a qualifying condition, but also an associated or complicating condition or symptom. And most states have some variation or iteration of all of these. And what I have listed here are some of the more common ones that are common across states, not just relevant to New York. And all these things came together, and in 2013, Columbia Care looked at it and decided, okay, let's organize all this information and let's put together what's essentially an individual EMR for each of the patients or customers, because they do pay for medical cannabis, and we'll talk about that a little bit. And they were able to put together a database that contained information on patient demographics, the conditions, the associated conditions and symptoms that we talked about, and the types of products that were purchased. So they would understand how much THC, how much CBD. In some states, they could even understand terpenes, things of that nature. And then also route of administration. Were they taking inhaled products, oral products, that sort of thing. The PDMP, which might be a bit of a tedious thing for some folks, actually comes to be a very, very large positive in this case, because the PDMP requires logging of cannabis but also other controlled substances. So they had information on narcotics, benzos, barbiturates, things like Lyrica, which I think is an interesting one to have in there. But all those things together, when you want to do an analysis, you can really start to understand what's the most effective product for a certain condition. You can understand a little bit about what product formulation might work the best, and a lot of information about dose ranges. And I think the key here, and this is something that Bonnie mentioned during her presentation, is all of these patients are customers. They have to actually purchase the cannabis. So understanding that repeat purchases could be a good surrogate for efficacy was a really important thing in this case. So at this point, the database is quite robust, and I won't walk through all the numbers here, but what we're going to do today is look at some of the information associated with chronic pain and also with neuropathy. And a good deal of neuropathy involves pain, so it's a really nice way to look at two things that are similar but very different as well. So the first pilot study is neuropathy. And what happened is the pharmacists in the dispensaries started to notice that there were a lot of opioid usage in the peripheral neuropathy patients. So they started to look at that relationship. And they recruited folks ages 18 to 80 who were using opioid products when they started their medical cannabis and looked at them over the course of time. And this was a 9-month period. And they found that 62% of patients were able to stabilize, reduce, or eliminate their opioids. And that was based on MMEs and calculating the totals over the course of the time period. And the decrease in its entirety was a bit different depending on whether the patient was a new start or a continuing patient. So if the patient was a new start, identified and followed prospectively, the decrease was about 22%. If it was someone that was already on the products when they started the study, the decrease was only about 13.8%. And I think that makes sense logically, because if you have someone who's already on a product, they don't have as much room to change. So their ability to have a delta is reduced just simply by the fact they've been on it for a while already. And as a counterpoint, it's important to note that about 28% actually increased their opioid usage during that time. And they tried to understand perhaps what was going on there, and a lot of those patients who did increase their opioid usage were patients undergoing cancer treatment, and they had cancer treatment-related neuropathies. So that leads you to believe that perhaps they were having extremely severe pain. So this breaks it down in more detail for you. And what you'll see on the y-axis is the total milligrams dispensed over the time period, and it's broken down into the 3 quarters here. And the dark blue bars represent the total milligrams of THC, while the lighter blue are the MMEs. And as a reminder, the MMEs went down by 21.9% in this particular group. And if you look at the slope of the line, sort of that dashed dark blue line towards the bottom of the slide, you'll see that the THC didn't particularly change. And that was probably maybe the most exciting thing about it, because when they started to do this, they were incredibly worried that all people were doing is substituting one problem for another. And they found out that wasn't the case, which is really fantastic. These data were pretty exciting to a group of researchers in New York, and researchers from the New York Psychiatric Institute, and NPI, I think is typically called. They verified that data. They used it to apply for a NIDA grant successfully, and they're still doing some analysis of a much more expanded data set right now. This, I'll be honest, I don't know a ton about, but I read it yesterday. It popped up in a Medscape article, and real-world evidence is catching on. Some of you may have been at Jeff Chen's presentation earlier today talking about real-world evidence and CBD. This is additional real-world evidence on cannabis, and it came out of the American Academy of Orthopedic Surgeons meeting, which happened in March. And they looked at chronic back pain and osteoarthritis, and they found that those with chronic back pain had a significant reduction in MMEs when they started medical cannabis, and they used the PDMP as well, and it was a pretty long study period, about 18 months, and more than 1/3 of the patients stopped taking their opioids altogether. And in the OA group, very similar results. It looks to be a shorter study period, and again, I haven't been able to find the original pieces. I made this slide on the plane on the way here, as a matter of fact. But again, about 1/3 of the patients stopped using their opioids. So I think it's really interesting, and I think folks are placing a lot more value on what's happening in the real world. So what other lessons can we learn from IMPACT? How to use medical cannabis for pain. I think Eloise went through really great insights there, and I won't spend too much time on this, but when you think about it, all pain is not created equal. And you know that some pain might respond better to a higher CBD product, while other pain elements might respond better to a higher THC product. And if we skip over to the far right-hand side of the slide, the higher CBD products tend to do better for neuropathic pain and inflammation, whereas the higher THC products respond better to the types of pain that typically require opioids. The actual drug delivery type matters a lot as well, and what the pharmacists have found in looking at these patients using medical cannabis for pain is most folks use more than one delivery type. And if you think about it, it makes perfect sense, and we can use the sort of illustrated PK on the right-hand side there to help us understand that. So the dark blue line represents inhalation. So the peak goes up really quickly. It's rapid onset, lasts for a little bit, maybe 2 hours, comes down just as quickly. So that's really nice for breakthrough pain. So you're going about your daily life, you have bouts of pain, but you don't want to have any sort of negative impact related to an adverse event. You want it quick on, quick off, and keep going. Whereas oral products, the gray line on that PK chart, have a much softer slope, a softer rise. They last a good bit longer, anywhere from 6 to 10 hours, and then they go off slowly as well. And that's really important when you think about things like being able to sleep through the night. If you have pain that prevents you from sleeping, you want something that lasts a bit longer. And then sublingual falls more or less right in the middle of those two. I'm not going to particularly talk about transdermal. There's a lot of, I think, there's not as much understanding there of exactly how that works, whether it's just about the actual physical application of the product causing some pain relief versus being penetration, things like that. But I think there's folks here much more qualified to talk about that than I would be. And now we'll go into the details of that chronic pain versus neuropathy. So these are some of the chronic pain patients. And to be included in this analysis, you had to have at least 3 purchases, so typically about 3 months worth of use of the product. And the chronic pain patients on average were about 53 years old, more or less an equal balance of male-female. And the most common prescribed ratio was a high THC product. And I use the word prescribed, even though the technical word is recommended, because they would come into the pharmacy and have this recommendation, this prescription, if you will, but they didn't necessarily have to buy those products. The pharmacist had the leeway to change it in most cases. And the most common product purchase aligned in this particular instance. So 55% were choosing the high THC products. And when you look at the per milligram daily dose, you see that it's not tremendously high, even when you compare the first invoice versus the most recent invoice. And we use the word invoice when we're talking about it because, again, it's a purchase, and you're looking at what was on that invoice that gets recorded in the PDMP. And the 2 horizontal lines reflect the mean. And what you see is the mean value for the first is 24.5 milligrams, and for the most recent was 35. Now, if we switch to neuropathy, we're going to see some differences in this information. So the average age for the neuropathy patients was a bit older, and they tended to be more men than women. Same most common prescribed ratio, that higher THC product. But when you look at the actual purchases, you see some differences here. So it's not equally a third, but it's pretty close to that. So patients were using different product types when they had neuropathy, and when you look at the actual mean dose, it's a lower THC dose. And if we think back to that chart I showed earlier, that makes perfect sense because of the way neuropathy causes pain. The higher CBD, less THC is required. So it aligned with just common practice and common thinking. So I'm going to close with a little bit on adverse events and what we've learned from the IMPACT database there. And we know that they vary based on product ratio, the route of administration, and previous experience with THC. And you can see a laundry list of AEs that have been reported, everything from sleepiness to increased appetite, dizziness, paranoia, nausea, vomiting, all of the things that we're all very familiar with. And I think the most important thing, and the thing that I always talk about when I talk to patients, is that you have to manage their expectations. If someone is aware that they might feel sleepy, it's less scary. It makes them feel more comfortable when they actually have that experience. And it's also important to understand that one person's side effect is another person's benefit. If I'm having trouble sleeping, I want a product that makes me sleepy. If I'm not, and I'm trying to get through my workday, I don't want to be sleepy. So really talking to your patients and really having very open conversations is always super important to manage those expectations. We did do an analysis of the data at Columbia Care specifically to geriatrics, and this was actually presented the last time I presented at CannMed in 2019. We presented the full data set on geriatric patients, but the portion I wanted to call out here was just related to the AEs, and the self-reported AEs were similar regardless of whether the patients were 70 plus or less than 45, which was this particular analysis. Increased appetite was the most common in both age groups at about 25%. And the most important thing, and I think Eloise hit on this a few times in her presentation, there weren't a lot of issues with disorientation or confusion. It was 6.3% of those 70 plus who reported that at any time. And usually it was with the first dose only, so it wasn't a long-lasting effect. And I think one of the most important things about that is it means it can be used safely. You can titrate up safely in these patients. And you can see some of the average doses there as well. And if anyone's interested in this particular data set, I can share the abstract with you. Or you can look back, I think, in the CannMed archives and see it as well. So in conclusion, when we talk about cannabis and pain, all pain is not created equal. It doesn't share a common etiology, and it doesn't have a common solution. And we need to think about it differently and think again about how we're taking care of these patients. And I think real-world evidence from registry data such as IMPACT can really help us understand what's happening, how people are using it in a practical way. And because we know that they have to purchase the product, it's a really good surrogate about efficacy. Adverse events vary based on ratio, route of administration, and previous experience. And, last but not least, more work is needed to understand all these best practices. Jeff earlier was trying to quote someone saying that every time you do one study, you need 4 more. I don't know who said that either, but I can quote you, Jeff, since you said it earlier. But it's very true. So thank you all for your time today.